Now we start the plenary session about clinical manifestation in MPS and treatment. The speakers have 30 minutes for presentation. Unfortunately, Dr. Kathman cannot be in this session, so the speakers can have more time. Questions are after each presentation. The first presentation is about therapies for the bone in mucopolysaccharidosis. Sanjay Tomasu is the speaker. He is director of Skeletal Dysplasia Center in Nemours Hospital for Children, Wilmington, and he is also professor of Department of Pediatrics in Thomas Jefferson University, Philadelphia. Dr. Tomasu, we give you the floor.
Okay, unmute. Can you hear me now? I think good.
Yes.
Okay. All right. Thank you very much, Maria. I appreciate that. I'm talking about today about the bone disease in MPS. Next slide. How to move? How to move next slide? Okay, here. Okay. First, I want to show about the spine X-ray pictures from MPS patients. As you can see here, almost the same age from MPS 1 through MPS 7. So if you can see closely, this is the vertebral body and the spine position. MPS 4 is the most, devastating, bone disease patients. Okay, and then MPS 1 and also MPS 4 or 6 and MPS 7, and then MPS 2 and MPS 3 is milder. So depending upon type of MPS, even we say bone disease, it's quite different. That's first things we have to know that. So another important thing is that when bone lesion will start, that's another importance. So this is already we published many years ago about one of the molecule patients. Even day one, we can see anterior beaking sign here about the body L1 portion. So then with months, it's getting worse and worse. Kyphosis and the humpback is more prominent. And then Pilates spondylii is prominent, quite compressed vertebral body. You can see that. So we cannot see any more like normal, vertebral, body structure, a square type. It's very flattened, and you can see that protruded kyphosis is here. So another important element how to reach bone is that why it's so difficult is that cartilage cell layer here is no vessel or avascular. That's another problem to deliver the drug here. Most likely, we cannot, many of drugs cannot reach directly here. Maybe bone marrow here and there, we can reach, but not directly here. That's another difficult portion about how to fix bone disease. So I want to talk about today several, therapeutic, issues about bone disease in MPS. Tracheal surgery, which it's started since 2015 in our group, ERT, HSCT, and gene therapy, and growth hormone therapy. So new tracheal reconstructive surgery it started in 2015 in our institute. 16-year-old boy under 2.5 years of ERT. This is MPS for a patient, breathing difficulty and started to use BiPAP. Diagnosed severe obstructive lung disease. CT and MRI demonstrated compression of anterior trachea by the artery. So tracheostomy is not a possibility because the parents diffuse because of lifestyle in future. So surgical procedure has been attempted of this boy. How it's difficult here? Imbalance of growth. It's happening in molecule or other type of MPS. It's generally speaking, it's straightforward. However, in MPS, especially molecule case, redundant and twisted, trachea will happen. So before operation, compression of trachea, over 95% of trachea airway is compressed. So cannot breathe actually, this boy. You can see that artery on top of trachea here, so cannot breathe anymore. It's very hard. So what we did is that first step is surgical relocation of innominate artery. So from here to here, trachea is here because this innominate artery is on top of trachea. That's a problem. So then afterwards, we dissect trachea here, and then we anastomosis here like that. So longer trachea should be shortened like this. That's most important. So straightforward. So after operation, trachea is now already open. So this boy can breathe very easily and can get more activity. Nevertheless, when we took the sample from trachea, biopsy sample, they are abundant of vacuolated chondrocytes, which means there is no impact by ERT. There is no clearance at all by ERT. That's another importance. So far, we involved actually our institute around 12 successful cases which received this new surgery. 9 cases are under ERT, and the tracheal obstruction is always over 80%. So respiratory status is always look up the sky position, loud breathing, loud snoring, shortness of breath, BiPAP or CPAP, completely wheelchair bound. Post-surgery, easy breath, no look up the sky position, no snoring, no artificial ventilation, marked improvement of activity of daily living. So this is a surgical experience. Although it's not the specific bone, but the trachea is a part of the bone we can deem as. That's why this is very important. Another important thing is that who would be the risk factor of tracheal surgery in MPS 4 is short stature. So bone growth is damaged during the progression of the disease. More chances to get this surgery. Already we have a publication for that. So therefore, how to get patients grow. That's another importance overall in MPS. So first ERT, MPS 4 case. We have a number of cases now under 5 years old ERT cases, studied ERT. But nevertheless, there's no changes compared with natural history data, which is showing male and female. And red one is a natural cause of the disease without treatment. Even after treatment by ERT, ultimately there is no change compared with natural history growth chart. This always happening not only ourselves but other group already mentioned about this fact. So important thing is that 20 surgical remnant after 60 months of ERT, no clearance of storage material in chondrocyte. ERT provides limited impact bone. Again, in type of MPS 4A, no improvement of bone pathology, no surgical improvement in pathology, surgical intervention, no decrease of the number. Urine case may decrease, but blood case has not decreased. That's another problem. So conclusion, conventional ERT provides very limited impact on bone growth and bone pathology in patients with MPS 4A. Same thing true in MPS 4A mice. How about HSCT? So I will show you several cases. First, HSCT and HSCT versus ERT from MPS 2 and HSCT MPS 4A. So this is a case report from our experience. He got HSCT 2 years old, and now 10 years past. He got kyphosis here. So because of that, we got the surgery to fix this kyphosis. Surprisingly, no storage in chondrocytes from a surgical remnant, which means HSCT may impact to remove the storage material. But nevertheless, still there is some still bone disease is a progress. Although a practice spondyli is still improved, so partially improved by HSCT happening in this case. His his height is around over 153 centimeter at 13 years old. Although still lower than normal control group, but it's better shape compared with untreated. So result is clearance of storage material, although still bone involvement remains. HSCT versus ERT impact growth in MPS 2. This is also published. This is from Japanese MPS 2 group, Hunter. You can see that this is a control growth chart in Japan, Japanese population. And the HSCT group here, you can see that broken line. And then ERT group here, it's parallel with HSCT group. Compared with the untreated group, definitely we can see the growth impact in terms of Hunter. So this is a very famous paper. Which this Hunter patient got HSCT very early stage, like 70 days. So he is now a 7 years old boy, and then compared with the uncle, brother and uncle, he is a very good shape. You can see that compared with completely wheelchair bound and bedridden condition, uncle. And he is a tallest boy in his classmate. You can see that almost no defect in bone. So you can see that. So which means HSCT definitely, if we do early stage, provides an impact of bone. That's you can see that. I don't know. Yeah, that's fine. So how about HSCT for molecule? Compared with MPS 1 and MPS 2. Unfortunately, maybe I cannot show you the video, that's fine. But important thing that if we do, 4 years old girl, 20 years later after HSCT, she is fully functioned. She can walk, she can do a full-time job. So there is no issue after HSCT. That's quite impact to activity of daily living. However, her tall is still 117 centimeter tall in final height, which means still bone growth is still limited when we do HSCT at 4 years old, because it's already nearly stopped growing at that time. So we need to know how much impact the bone if it's very early stage HSCT in MPS 4, like Hunter or MPS 1. which we don't know yet at this moment. How about gene therapy? So we have a targeting gene therapy, which is a bone targeting gene therapy system, which we created, we produced. What the meaning is that general, native capsid almost all goes to the liver, although some parties other tissues. But if we can change the tropism of capsid, AB vector, by adding it's called acetic amino acid, negatively charged. How different? This is a hypothesis. It may go to the liver, but it may go to the more to the bone. That's our hypothesis. So this is a hydroxyapatite binding assay, which is hydroxyapatite is the most abundant bone matrix. So if you see that empty AB or enzyme, okay, with AB vector, compared with bone targeting capsid AB vector, 100%. This is the in vitro assay, though. 100% of bone targeting capsid attached with hydroxyapatite. So if this is in vivo data after infusion of AB vector, bone targeting or non-bone targeting. So you can see that 2 weeks later, compared with wild type, which means non-bone targeting AB vector, bone targeting vector is going to over 1,000 more and going to the bone. This is enzyme activity of molecule A enzyme, Gallon's enzyme. So compared with bone targeting enzyme, compared to wild type, so non-bone targeting enzyme is very low, but bone targeting enzyme is around 58% of wild type level. That's we can reach. I will skip. So then, how about if we put a bone targeting system attached to the cDNA, which means Gallon's enzyme itself? So we started a treatment at the 4 weeks old molecule mouse model, knockout mouse model, and then we compared bone targeting versus non-bone targeting enzyme. In this case, again, enzyme. So you can see that bone targeting enzyme is quite high enzyme activity level during the process of gene therapy after injection at 4 weeks old. Okay, through the until autopsy age, 16 weeks old. So compared with non-bone targeting enzyme, it's circulated more enzyme. Creatine sulfate level, you can see that we are using 2 mouse model, knockout and immune tolerance mouse. So this is untreated mouse. It's compared to untreated mouse. All kind of treatment group going down about a plasma Ks level. Bone Gallon's enzyme activity. This is ubiquitous CAG promoter, D8. Compared with non-bone targeting, in this case, there is not much difference, no statistical difference. You can see that. How about growth spurt lesion in pathology? Untreated mouse is quite, column structure is distracted, and also abundant of bone chondrocyte, vacuolated chondrocyte. After treatment, this is non-bone targeting, this is bone targeting enzyme. So you can see that the bone targeting enzyme is a more clear clearance of vacuolated cells and storage material, and also column structure is better than the native enzyme. Micro CT analysis is showing here. Untreated knockout, it's quite dense trabecular proliferative structure compared with wild type. But once it's treated by AAV gene therapy, both non-targeting, bone targeting is more, actually inhibit proliferative trabecular situation. That's, you can see that. Right? So how about growth hormone therapy? In the past, several groups actually treated by GH on several types of MPS. This is from literature, not our data though. So background of GH, growth hormone, has been found to have other beneficial effects besides the impact on growth and bone, like exercise performance, also showing muscle mass and decrease fat mass in children, and also increase pulmonary function. Therefore, it could be worthwhile to treat by growth hormone. Also, it's approved drug. So this is one of the paper from Dr. Poligreen's group, MPS1. So they checked MPS1. So what looks like, okay, female and male HARA patients. So after treatment by growth hormone, how looks like. Okay. So this is a treated group. So you can see that. But when you see that, of course, there is some impact by human growth hormone compared with untreated. MPS2, there are two cases they presented. They defined no growth hormone, so which means growth hormone deficiency, two cases. So therefore, they started to treat by growth hormone. So looks like growth velocity increased 10 to 3 centimeter after 6 months of treatment. But then afterwards, it's decreased in after 12 months. So which means short kind of therapeutic impact happening. Same thing through another patient as well. So first impact is a 14.2 centimeter growth velocity, but after 6 months it goes down. But nevertheless, compared with before treatment, it's better. That's they said. And so far, there is no adverse effect by using growth hormone. So this is from MPS2. This is untreated, and this is treated. You can see that. So growth velocity not significantly different in human growth hormone treated individual, which means untreated and treated maybe not much different, statistically not different. All children with MPS treated with human growth had an increase in height. Individual treated with human growth had greater gains in bone mineral density and lean body mass. That's another good thing for by using growth hormone. No safety concerns. So of those individuals treated with human growth hormone, if they were growth hormone deficiency, looks like a trend towards higher annualized growth velocity compared to without growth hormone deficiency. So which means they are indicating maybe if we find out some growth hormone deficiency before treatment, maybe more better idea to treat by human growth hormone. So MPS 4A case, they treated one cases because of a poor IGF-1 level. However, it's not much impact by treatment. Although they said it's increased 4.7 centimeter per year, but year 2 it goes down. That's 2.3 centimeter. Okay, so therefore they started also estrogen replacement after 2 years of human growth hormone treatment. So sometimes a combination of a growth hormone with estrogen could be important. They are suggesting, because bone age and bone mineral density are also improved by doing therapy. And MPS 6 case, one case they treated since treated ERT, so it's really not growing well. So because of that, they started growth hormone. Okay, so baseline is 2.3 centimeter per year. That's it said here, and it's improved 5.9. Second year of 4 centimeter. Third year 4.1 centimeter. So therefore, they suggested there is some impact by the growth hormone. So another group, Goldman group case report though, they treated MPS for a 9-year-old ERT at 2.5 year, 7-year duration. Almost no growth impact. So because of that, they started 8 years, 131.3 centimeter, 2 years duration. I'm sorry, this is attenuated phenotype. So within 1 year of commencement, you can see that IGF-1 concentration is increased, and the GHT is continued to date. That's showing. So this is an older case, which there is no treatment by growth hormone. It stopped growing, 9 years old. In this index case, started growth hormone at 9 years old. So they claimed that there's some growth velocity increased in 2 years after growth hormone treatment. That's they claimed. Another group is, this is a Italian group, quite important maybe. They screened among 64 MPS patients. So then they encountered 4 MPS female patients had a growth hormone deficiency. Therefore, they treated by growth hormone. So this is MPS 1 case, ERT studied at 15 months, case 2 13 months, and HSCT each cases early intervention by HSCT. And then you can see that since it's growth delay is happening, so they started growth hormone therapy. Here you can see that. So then they claimed it seemed there is some regrowth happening after human growth hormone. MPS 4A, again, this is a growth hormone deficiency case. No impact of bone growth. So therefore, they studied growth hormone 9 years old. So remarkably increased from 0.16 centimeter per year to 3.3 centimeter. That's they claimed. So here you can see that almost stopped growing by joining ERT, and then they studied a human growth hormone. It seems there is some impact to the bone growth. That's they are claiming here. Okay, I will skip this one. Only MPS 6 case. Again, after human growth hormone treatment, there is some degrowth it's happening. That's they are showing in MPS 6 case as well. So looks like human growth hormone treatment appear to have effectively divided the growth retardation experienced by MPS patients diagnosed with growth hormone deficiency, at least during the first 1 to 2 years. That's the current conclusion. Although we don't know, like 3 years, 5 years, a long-term, observation is required. So our goal is that for the bone, or not only for the bone impact, safe, one time, of course, is the best, less surgical intervention, and cost-effective. Make a risk-benefit assessment. That's very important. That's fine. Yeah. You can see that HACT patient. This one is a Hunter. This is a 4 years old HACT patient. Now she is around 30 years old. She can walk in a good way. There's no problem, no restriction, full-time job. So if we do, early stage with HACT treatment, there's some definitely impact. But again, about the bone growth is, not so easy to fix, especially in MPS 4A. So far, there's no real improvement of bone growth by HACT or ERT. That's the current conclusion to avoid the risk of future, tracheal surgery. So therefore, how we can improve bone growth, very important. This is acknowledgement. Thank you very much for many collaborators internationally. I really appreciate that. Thank you.
Thank you, Dr. Tomasu. Very interesting presentation. Now we have some questions of the public. The first one of Natalia Gomez Ospina. She says, I have been very impressed with the results of HACT in patients with severe MPS 1 diagnosis with newborn screening. The patients were transplanted 2 months and 2 years post. HACT bones look normal and growth is normal, but we can start to see some joint stiffness. I still don't know what to tell the families as to the long-term impact on health and bone disease. Are you aware of long-term outcomes for patients that are transplanted so young?
Yes, since we are now available to have newborn screening for MPS 1, maybe in the near future other type of MPS. This is a very critical moment. If we treat by HACT newborn affected newborn MPS 1 or whatever, I think consequence is much better for bone growth. Except I don't know about MPS 4A at this moment. Okay, because important thing is that consequence is quite a difference between MPS 4A versus other type of MPS. Because MPS 4A is chondrocyte, cartilage cell layer is crushed, disrupted mainly. However, other type of MPS is different. Osteocyte, osteoblast, other component could be measured. Therefore, bone is thick in other type of MPS. But MPS 4A is bone is thinner. That's big difference. Okay. Even we say a shorter stature. So therefore, type of but depending upon type of MPS, HACT consequence is different. Although Gomez Natalia mentioned about joint mobility issue in future, 2 years, 3 years, 4 years. I think still, we may have some, kind of a problem. But still, early treatment affected newborn is a better consequence for sure in bone growth. Again, except MPS way, we don't know at this moment.
Okay. Next question of Carlos Javier Alméciga. If growth plate is not vasculated, how can the gene therapy reach in the chondrocytes?
Yes, that's definitely what I'm talking about. Again, in MPS4A case, cartridge, okay, growth plate is a major defect, okay, compared with other type of MPS. So because of that, if drug cannot penetrate in cartridge cell layer, nothing may happen. Even tons of enzyme is produced by whatever gene therapy. Still, if we cannot penetrate the cartridge, maybe a minimal impact to the bone growth. That's this is frontier area which nobody can dissolve in MPS4. This is what I have to be honest. Okay. Nobody knows the answer at this moment, how to penetrate the cartridge cell layer, especially enzyme, such big molecule. But a small molecule may have a chance, maybe can penetrate cartridge cell layer. So we may need conclusion is that we may need some enzyme plus small molecule treatment, maybe required for in terms of MPS4 in growth plate region, especially.
Okay, thank you. For gangliosidosis GN1 bone deformation, do you have any treatment?
Excuse me, please say again, Maria.
For gangliosidosis GN1 bone deformation, do you have any treatment?
I don't think so. At this moment, I'm not aware of that. Problem is that many scientists and doctors, including a pharmaceutical company, are moving forward to CNS, but less, interest to the bone. That's as far as my knowledge. So we should move forward to the bone more, because the bone is the most difficult organ. Could be more difficult, beyond the CNS. Again, problem is that avascular, cartridge area.
Okay, last question. Does early ERT use in MORQ-A patients lead to bone growth?
Could you please say again, Maria?
Does early ERT use in MORQ-A patients lead to bone growth?
What the treatment you said?
Yes, if early treatment in MORQ-A improve the bone growth.
Oh, okay, yeah. So again, as I told you,
with enzyme replacement therapy.
Yeah, ERT cannot, unfortunately, at this moment, okay, there is no proof ERT can improve bone growth. Even we did, at early stage. We know that the mouse model cannot improve, even started at the neonatal stage. In human, we have known, like even within 2 months, we started, still no bone growth impact, very minimal. So therefore, definitely we need, another kind of treatment for sure, specific to MORQ-A.
Okay, thank you very much,
Thank
Dr.
you very much.
Tomás.
Yeah, thank you. Bye-bye.
Next presentation is neurosurgical management of MPS. The speaker is Santiago Caldela. He works in the Department of Neurosurgery in Sant Joan de Déu Children's Hospital in Barcelona, Spain. Dr. Candela, when you like.
Thank you, Dr. Acoce, for the introduction. I feel very honored to be part of this meeting. And as a neurosurgeon, I will talk about the neurosurgical aspects of MPS. My presentation, I don't have control of the, yes. Okay. My presentation will be not so interesting as Dr. Tomatsu, but it will be shorter. I have done a presentation in 2 parts. The first part, I will talk about the classical neurosurgical problems in MPS. And afterwards, I will talk about technologies we use to infuse the different treatments to the targets. Okay, so I have problems with the control. Okay. Mm-hmm. Okay, so generally speaking, these are the main problems of NPS related to neurosurgery. We have in the left the main NPS types and the different neurosurgical aspects. We have spinal cord compression, aldoaxial instability, kyphosis, scoliosis, hydrocephalus, craniosynostosis, and subdural hematoma. You can see that different types of NPS have different neurosurgical problems, and we will talk about them one after another. Okay. Okay. So the first is spinal cord compression. It's typical in NPS 1, 2, 4, 6, and less, but also in 7. Most often it affects the craniocervical junction and thoracolumbar junction. It can appear in one segment, but also in more than one. And the age of presentation severity vary widely between and within the NPS disorders. It results from spinal canal stenosis, which generally develops due to hypoplastic vertebral arc and thickening of the connective tissues, dura mater and ligaments, and the surrounding spinal canal secondary to glycosaminoglycan accumulation and fibrosis, epidural lepomatosis, and or degeneration of the vertebral bodies. It may be exacerbated by aldoaxial instability, especially in MPS 4, and kyphosis or kyphoscoliosis frequently occur in patients with MPS 4 and 1, which contribute to lumbar compression. Well, as said before, it can occur at different levels. You can see pictures of a schema of the causes of the compression and examples of compression in a patient with MPS 4 of 9 years of age, and at the right, an example of MPS 6, both with cervical compression. Okay, so what's the management of the spinal cord compression? Of course, if it's symptomatic, surgery, because if it is left untreated, it can lead to compressive myelopathy and neurological deficits that we need to avoid. Weakness, gait abnormalities, paraparesis, pyramidal sinks, etc. So neurological examination is very important. Imaging, flex extension imaging in MPS 4 and 6, where instability is a problem, are recommend. And MRI is the most valuable imaging technique, but of course in small patients it requires sedation, but it is for to do in these patients. And the most important is the somatosensory evoked potentials that can detect this problem before we can see myelopathy in MRI, or we can detect clinical signs. So the management is surgery, primary descompression, laminectomy, laminotomy, laminoplasty. There are different techniques depending on what we do with the bone. We can just open, do the bone larger, or take this out. That is the most frequent. And if there is also instability, we have to do also fusion. The most frequent is do dorsal decompression because it's the most easier and safe for us. And of course, if there are myelopathy signs or clinical signs, surgery is mandatory. But if there is significant instability, also more than 8 millimeters in CT or X-ray, in the distance of odontoid to Atlas, we have to fix this vertebra. So there are some physicians that recommend prophylactic fusion. Well, in our case, we only operate when there are neurologic things or the somatosensorial potential effect, because if we operate too soon, patients develop always fibrosis, they can do new bone, and then reoperation is more difficult. So we wait until the patient has problems detected by MRI or the SSIP. Because it's an important surgery, and it has, as every neurosurgery, it can have complication. The most important, the most challenging are motor worsening due to neural damage. Sometimes, not sometimes, always the neural structures are too compressed, and operating in that area is challenging because of edema, or surgical manipulation can sometimes do that the neural deficit worsens. So intraoperative neurophysiological monitoring is very important to be able to detect these problems as soon as possible. And well, sometimes we have problems that instability or the stenosis progresses downward, and we have to do larger decompression the second time, or the risk of anesthetic problems, especially in intubation, the airway management, or myelopathy due to flexor extension maneuvers during intubation. And another complication, we had one case of thoracic spinal infarction during the cervical decompression distantly to the surgical site. The alloaxial instability, as I said before, is typical in MPS 4, but it can also occur in 1, 6, and 7. And it is due to odontoid hypoplasia, often in combination with ligamentous laxity in patients of MPS 4A. And this subluxation can occur during the anesthetic management, as I said before. So it's very important to use fibroscopy for anesthetic maneuvers. And well, in that cases, always posterior occipital surgical fusion is mandatory, and sometimes previous transoral approach is necessary if an anterior compression is also. For instability evaluation, we are using now, better than simple X-ray or dynamic CT, dynamic MRI, because it allows us to see the neural structures and the relation with the bone structures in neutral position, flexion, and extension. And it's very useful. In that case, it's nonsense because we see the myelopathy signs, but there are some cases that we can see the instability in the MRI, and we were not able to see them before with the simple X-ray or CT. So dynamic MRI is very useful to study instability. Hydrocephalus is another problem in these patients. It's always communicating. It's an increase in ventricular volume, and it can occur with intracranial pressure and microcephaly. It's most prevalent in MPS 1 and 2, but might also occur in 3, 4, and 6. And the physiopathology of hydrocephalus in MPS patient is due to the engorgement of the arachnoid granulations by accumulated glycosaminoglycans, the obliteration of the subarachnoid space by them, and also a reduced venous drainage through the skull base due to the anatomical abnormalities. The increase in ICP can manifest in headache, nausea, vomiting, incontinence, and sudden blindness due to optic nerve compression and papilledema and optic nerve atrophy. We have to differentiate hydrocephalus from brain atrophy, and in some cases can be necessary to do an ICP monitoring for this purpose. The optic nerve study is also useful. And DPS is the most effective treatment. The endoscopic third ventriculostomy has an effectivity of only 21% versus 73% of shunting. That's because it's communicating, not obstructive. ITV is more for obstructive cases, and it's not the case in MPS. There are lots of kinds of shunts. There are shunts of fixed pressure. We, in pediatric patients, usually use shunts that work at 70 centimeters of water, but there are 40 of 90, depending on what you are treating. But we are used to employ the 70 ones. There are shunts that you can program them, but they usually misprogram with the MRI. So there are also some models that are made to don't change programmation with the MRI. They are the ones that we use now for complex patients. And there are also some shunts that have anti-gravitatory devices that avoid this problem when the patients change position from the cubitus to the station. Another problem is craniosynostosis that can be present in patients with MPS 1, 2, and less frequently 6 and 7. It is usually an aesthetic problem, and we have to take in consideration the life expectancy of these patients in order to treat or not to treat them. But in some cases, there is also intracranial hypertension and papilledema, and in that cases, treatment is mandatory. Treatment includes usually cranial expansion. If there is ICP, it's the treatment of choice. But in some cases that we operate only for aesthetic purposes, and if the patient is young, we can do saphorectomies, as we can see in that video. It's assisted by endoscopy. We do a small incision that is a coronal, suture closed, and well, we are open the bone closed with real view through the endoscopy. Then we open the suture, and then with the patient growth, the statics improve also. If we arrive late, then cranial extension is mandatory. We can, for example, this is the frontoorbital advancement. We do this surgery in older patients, more than 9 months old. And the suturectomy is in patients around 3 to 5 months old. And another problem is subdural hematoma, typically in type 3 in San Filippo. We have seen 2 patients also with subdural hematoma, and they are very complicated to treat because they recidivate one and another, and sometimes we need to treat by open surgery, not only through burr holes. They are difficult to treat sometimes. Okay. So now start with the second part of the presentation. These were the classical indications of neurosurgery for NPS patients, but now neurosurgery is taking part in supporting neuropediatricians and investigators to deliver the new treatments to the different targets in the brain. The most frequent target is the ventricular system. If the patient has hydrocephalus, it's easy to approach the ventricular system freehand, but sometimes or many times ventricles are small or are slit, and we need different assistance techniques. We can do a simple puncture if we need to do one administration of a drug, or we can leave a reservoir if we need to do different approaches. And what are these different techniques that we have to assist us for guidance? For the ventricle, for example, we have used the electromagnetic neuronavigation. Electromagnetic neuronavigation is a dispositive that we don't need to fix the head of the patient to the operating table. It has a magnetic probe and the electromagnetic receiver. We do. I will show you in a video. And well, it's precise. We have an accuracy of 2 to 4 millimeters. If we need more accuracy, then we have the stereo. For example, for intracerebral administration drugs, we have the stereotaxy systems, the stereotaxy frame or the robotic arm, etc. The same for intracerebral administration. There are also targets at the intracisternal level. We don't like them, but we can do. We don't need to go through the brain. But this approach has very important targets around. It's a little bit dangerous. So we feel relatively safe only if we do this technique with intraoperative MRI or intraoperative CT scanner, not without them. Of course, for lumbar puncture, we don't need any kind of technology. So what is stereotaxy? I told you before that for accurate administration of drugs, we need these kinds of guidance. It comes from the Greek stereos, 3D, and taxis, positioning, and it is based on Cartesian coordinates. The system began in the 1980s with Horst Ironclad that developed the stereotactic frame that was used in monkeys. Some say that it was also used in humans, but not officially. The first system employed in humans was in 1947 in Philadelphia by Spiegel and Wysis, and in Europe in 1949, in France by Talleyrand, and in Sweden by Lexen. These are different systems. There are many different systems. And nowadays there are multiple stereotactic systems. So as you put the trajectory, the first is the stereotactic frame that you can see up in the left, or neuronavigation-based system down in the left. The through optic is the one in the picture, or the electromagnetic I will show you later. We can use 3D printed system. As we can see in the right, up and down is called the star fix. You put some fiducials in the head of the patient, do a CT scanner, and then this brand provides you a stereotactic frame 3D printed that you fix to the fiducials you have previously inserted. You can use a robotic arm that is also used in optic technology or in ultrasound technology, the one we use, I will show you. And intraoperative MRI or intraoperative CT system. In the picture, there is an intraoperative CT guided navigation. But all these are based on the stereotaxy coordinates. Now, in San Juan de Déu, we use a robotic arm for intracerebral administration of drugs with the assistance of the intraoperative MRI that we can use for code registration and also for postoperative control. I will show you a video of the patient. That is the operating room. And we have the MRI device beside the operating room, and we transfer the patients through this transfer table. Well, of course, all the material inside the MRI device is MRI compatible. And we can do also procedures inside the MRI. We use this technology for complex administration that we need better accuracy. If we don't need so much accuracy, we can use the electromagnetic navigation. In that case, we don't need to transfer the patient to the operating room. We can do in the operating room. And as I told you before, we have this tip tract magnetic. We have previously done the registration, and we guide this catheter through the previously acquired MRI. This is not real-time image. Okay. And a new technology that I would like to have in my hospital, I hope to have it soon, is this a system of intraoperative MRI guidance. You can operate inside from the beginning. We don't need to transfer the patient to the operating room, to use the robotic arm, to insert the cannulas or catheter. You can do all the surgery inside the MRI device, inside the magnet, what is safer for the patient. Every transfer to the operating room and back to the MRI facility is a safety problem. And as you see, you have a software that allows you to correct the trajectory and to see this is real time inside the MRI. You see where are you in each moment, and you can see with real time MRI how you deliver the drug with a specific pump, of course, MRI compatible. I hope to incorporate this technology soon to our hospital. Sorry. Can we go back? So to finish, as told at the beginning, MPS have a wide spectrum of neurosurgical conditions where neurosurgeons can help our patients. Spinal cord compression and abduction instability are the more frequent, especially in MPS 6 and 4, respectively. Hydrocephalus, synostosis, and subdural bleeding must be considered in 1, 2, and 3. But the neurosurgery role is turning to help with the etiological treatment of MPS with this guiding technology for the drug delivery and the intraoperative MRI guidance for agent infusion will increase stereotaxy safety. And that's all. Thank you.
Thank you very much, Dr. Candela, for your presentation. Very interesting. We do not have questions from the public, but I have one question. Do you consider that pediatricians generally take longer than they should to assess neurosurgical treatment in patients with MPS? For example, as the ventricular peritoneal shunt for hydrocephalus.
In my hospital, no. We are
In general.
very no. We have very good relationship with Dr. O'Callaghan, with Dr. Pineda, with Dr. Darling. We work together and we don't have any problem. As soon as they detect a problem or they have suspicion of a patient that can require our treatments, well, they come to, they knock our door, and no, we don't have problems in our hospital. I don't know outside, but in San Juan de Déu, no.
But they have very experience, but in general, I think is probably that
probably patients that came from outside our hospital, they could arrive later, but I cannot tell you because we don't have this problem.
Okay. Okay, thank you very much for your presentation. Now, the last one presentation is clinical and radiological aspects of respiratory involvement in MPS and lysosomal storage disorders. The speaker is Paola Faverio from Italy, of Respiratory Unit San Gerardo Hospital, Monza, Italy, and University of Milano Bicocca in Italy.
Good evening, everyone. Can you hear me?
Okay.
Can you hear me?
Okay.
Okay, thank you very much. Good evening, everyone, and thank you very much for your kind invitation and kind presentation. I am a respiratory medicine doctor from a university hospital near Milan. I work in Monza, and our clinic has particular expertise in interstitial lung disease, and this will be part of our presentation today. I have no conflict of interest to declare in regards to this topic and presentation. So in the next 20 to 25 minutes, our aim is to give you an overview of the main clinical and radiological aspects of respiratory involvement in MPS and lysosomal storage disorders. So let's start. As you can see, as you can see from this slide, sorry again. As you can see from this slide, the spectrum of respiratory involvement, lung involvement, and airways involvement in lysosomal storage disorders and MPS is quite wide and huge. We will focus on some of these aspects, and just to treat and to give you a fast overview of all of these, we can start from involvement of upper airways, main airways and trachea. Already in the first presentation, Professor Tomatsu gave us an example of tracheal stenosis and compression, and we will also talk about that. But not only the main airways may involve, but also the smaller airways, and this is the part where the pulmonologists like me are also involved, in particular on bronchial stenosis that can also mimic other respiratory diseases, such as asthma, for example, particularly in young adults. And again, we can also observe pulmonary vasculature diseases that can lead to pulmonary hypertension in some of these patients. And again, focusing a little bit more on lung parenchyma on the right side of the slide, you can see that we also can have interstitial lung disease, so interstitial lung involvement. We will see some images, we will see some CT scan from these patients, mainly taken from the literature, because this involvement is quite rare, but must be taken into account and considered in these patients, particularly if some symptoms that we will see together are present. And again, not only the lung and the airways may be involved, but also the chest wall system and also the muscles, particularly the diaphragm, may be involved, particularly in some diseases. And again, we will see particularly in pump disease. And this must also be taken into consideration because chronic respiratory failure may develop if this complication is not treated. And we will see how we can treat it, not only with specific therapy, of course, but also with some non-invasive techniques, such as BiPAP and non-invasive ventilation. Again, Professor Tommaso already talk a little bit about this, but we will see it again. So you see really a wide, huge range of involvement, and we will try to focus a little bit on every aspect. Okay, so let's start from the airways. Again, we see that the trachea and upper airways can be involved. They can be involved in MPS with the formation of mucous membranes and redundant airway tissue, leading to obstruction and sleep disorder breathing. This is another problem. There's sleep disorder breathing that can develop with particular and specific symptoms that we will see. Again, tracheobronchomalacia and also tracheal obstruction, and we will see an example. Fabry disease, we have a cohort of patients in our hospital with Fabry disease of the adults that we follow up for airway obstruction can also be present. It's not common, but can be present. And this can be due to the deposition of glycosphingolipids, leading to, again, or sleep disorder breathing, or again, also bronchi obstruction. And then, again, talking about bronchi obstruction, so obstruction of the small airways, we can observe irreversible airway obstruction leading to wheezing, for example, or to dyspnea. And again, progressive mucosal thickening and the airway narrowing with accumulation of dense secretion. So also mucus production and difficult to expectorate mucus may be a problem in this kind of patients. So starting from this first point of airway obstruction, which are the main signs and symptoms we should focus on, we should consider in our patients? So definitely wheezing, not only reported by the patient, but of course also visiting the patient. So at lung auscultation in this patient is definitely fundamental. Dry cough, which is usually an irritative cough, but again, we have just seen that this patient may also have, in the more advanced stage of the disease, also mucus production. So in this case, the cough may become productive and the mucus may be difficult to expectorate. Shortness of breath, of course, is not the first symptom, but if obstruction is not treated, definitely it can become something important. Originally, it can be present under a fort, but it can also develop lately at rest. And then if we only consider the main airways, so trachea obstruction, for example, also tirage and cornage, even only looking at the patient breathing may be a finding to pay attention to. Then how can we diagnose airway obstruction? Particularly, I'm here focusing on bronchial obstruction. For respiratory medicine doctor that are listening to this presentation, of course, the answer is obvious. The respiratory obstruction, the main method to diagnose is the spirometry. Spirometry is a simple test used to help diagnose and monitor lung conditions by measuring how much air you can breathe out in one forced breath. So it's a very simple exam. It takes usually 5 to 10 minutes to perform. It's of course non-invasive, and the only thing that the patient must be able to perform is a deep breath in and a deep breath out. It's carried out using a device that can be also portable, as you can see from this image, which is the spirometer, and which is actually a spirometer. We can have information on many different information for the patient. So also, even if it is a very simple exam, it can give us information on lung function, lung volumes, and flows. So it is important to perform actually in every kind of defect we suspect in our respiratory system and in our patient. So how we perform a spirometry? So as you can see in the second image, a deep breath can be taken in and then the mouth is placed tightly around the mouthpiece. And then the next step after the deep breath in is a deep breath out, so that we can perform the maximum inspiratory and expiratory effort of the patient. And so which is the result that we can obtain from this simple maneuver? It's actually, it's not, they are numbers. We can obtain many volume and flows number for physiopathologists, expert physiopathologists, and also curves. So this is one of the curves that we can measure, that we can observe, is the volume time curve. But most important, I can say, is the flow volume curve. This is the main curve that we can observe with spirometry, which is very useful to diagnose an obstruction or a restriction in our patient. And this is fundamental because restriction is usually due to a number of respiratory complications that are not the same of obstruction. In this case, we are focusing on obstructive diseases, so obstruction of the airways, particularly the small airways, so bronchi. And if we have an obstruction of the bronchi, the curve, the shape of the curve that we observe is the blue one that you can see in this image. So you see, when we have an obstruction, the lung volumes are usually preserved, but there is an alteration in the flows. So there is a flow limitation due to the obstruction. And this may be less or more severe, of course. We can also see, this is not the topic in this first part of the presentation because we are focusing on airway obstruction again, but we will see later interstitial lung diseases, interstitial lung involvement, and also chest wall involvement and the muscle involvement. In those cases, the curve that we observe at spirometry is usually a restrictive curve. So the curve that we can see here in the orange color. You see the curve is very different. In this case, so in a restrictive patterns, we have a preserved volume, preserved flow of our patients. So there is no problem of obstruction. The flows in the airway are all right. The problem is in the volumes of the lung because the lung volume is restricted, and it is restricted maybe because of a problem with lung parenchyma, interstitial lung involvement, or maybe because of a problem with a muscle and the chest wall. So you see from these very easy to perform exams, spirometry, very fast, non-invasive, not even painful, we can obtain many different information in patients that, as we will see, in the same MPS may present maybe both patterns. So this can help us to discriminate between one situation and the other. So you see how useful this exam can be. Then I would like to focus with you a little bit more on main airway obstruction, and talking about main airway, of course, I'm referring to trachea. This is an image from a case in our hospital. And as you can see from this 3D CT scan reconstruction, there are two tracheal narrowing and also tracheal tortuosity, of course, so from the yellow arrow. And you can imagine that in this case, of course, airway obstruction is present. Again, of course, the CT scan is the main method to diagnose the place and the severity of the obstruction. But before performing a CT scan, again, the hypothesis of this alteration may be present, both looking at the patient mechanical of the patient way of breathing. So if he presents tirage, cornage, wheezing, also at lung auscultation, but again, spirometry may also help us once again. And why am I saying so? Because in the main airway obstruction, so tracheal obstruction, there are particular shape of the spirometry that make a sort of diagnosis and require further exams. As you can see from the first arrow, the red arrow, you can see that in this case, we have a normal inspiratory shape of the curve, the one behind the line. But if we look at the expiratory shape of the curve, you see that there is a sort of plateau. So there is an alteration of the conformation of this curve, and this is diagnostic for example, tracheomalacia. So for all those conditions that give us a variable intrathoracic obstruction, variable because of course tracheomalacia may change according to the phase of the inspiration or expiration. Again, another example of another spirometric curve is the following. When you see we have an alteration of both the inspiratory curve and also the expiratory curve, so behind and above the line. And the alteration is that we have a plateau both in the inspiratory and the expiratory curve. And this is typical of fixed intrathoracic upper airway obstruction. So for example, with tracheal obstruction or with tracheal compression, which is of course not variable between the inspiratory and the expiratory phase. So you see, if you see a patient with suggesting signs and symptoms and this curve at spirometry, of course, it requires other exams such as the CT scan. So you see how useful it can be in this kind of patient. Again, talking about obstructive patterns, the therapy, of course, is disease specific in case of the different disease I can observe. We have, for example, cited Fabry disease, but also sometimes we try a sort of trial, an attempt with bronchodilators. Again, bronchodilators, there is no definitive evidence on the use of bronchodilator in this kind of disease, not even in Fabry disease, which is probably the disease with more experience, with more cohort of patients described in literature. However, we think that maybe we can try an attempt. Actually, bronchodilators have no big side effects. We use a small amount of bronchodilators and we try if given this chance can improve a little bit the situation. However, of course, this is kind of observational and not confirmed by big trials. Then let's talk about the interstitial lung involvement in MPS and lysosomal storage disorders. Again, these can be very various in the aspects. I will show you some examples of CT scan, and it is quite rare. Probably the disease where we can observe it quite a little bit more often, but still rare, is Niemann-Pick disease. But we have other examples, for example, Fabry disease, where this involvement is really anecdotal. And we will see there are only 2 cases reported in literature. So let's start from the clinical signs and symptoms that we can observe in patients with this kind of involvement. Of course, again, one of the signs, or one of the more initial signs that we can observe is dry cough, and also shortness of breath initially during effort, and then in the later phases also at rest. If we look at the Niemann-Pick disease examples of interstitial lung involvement, you can see that we need a chest CT scan to make the diagnosis. Of course, chest X-ray is not enough to describe the pattern. And again, the best exam would be a high resolution CT scan. We can observe a big amount of different images, starting from ground glass opacities, but also interlobular septal thickening, interlobular lines, and these are probably the most common in Niemann-Pick disease, and they are more frequent in the lower lung zones. However, there may also be rarer expression, CT expression, which are crazy paving pattern, but also cystic pattern and pulmonary centrilobular nodular opacities. We can see here 2 examples taken from the literature. On your left side, I would say, yes, on your left side, we can see an example of septal thickening. Definitely all these white lines should not be present in a normal lung. So we have interlobular septal thickening. In this other case, much more complex, as you can see, we have the example of crazy paving pattern. What is crazy paving pattern? Crazy paving pattern is an association of ground glass opacities you see all these gray zones are not normal. This gray zone attenuation is called ground glass opacities. And we also have interlobular thickening above the ground glass opacities. The association of ground glass opacities and interlobular septal thickening is called crazy paling pattern. So it's quite rare, but can be observed. Other examples also of CT scan are on your left, a pattern mainly of ground glass opacities with just a few septal thickening, and again on your right, quite a lot interseptal thickening. Again, knowing that patient is affected by mucopolysaccharidosis make the diagnosis quite clear. However, it should always be considered to also investigate other possible diagnoses of these CT scan alterations. For example, this example of interlobular thickening may also be present when patients have tumors, and in particular lymphangitic metastasis. So, you consider the main diagnosis should be this, probably if patient is affected by mucopolysaccharidosis. However, always also consider differential diagnosis if the CT scan also is suggestive of or not excluding something else. So always to make a workout. Then we have some example of Gaucher disease. In Gaucher disease, interstitial lung involvement is rarer, actually. However, we can have it. And it is also characterized, for example, by the ground glass opacities and interlobular thickening, as you can see in this image. And if it can evolve, it can develop to also lung fibrosis. And once lung fibrosis is developed, this part is irreversible because we have these scars that cannot be reversed. So the aim would be to make an early diagnosis to prevent the evolution of the disease. Again, a restrictive pattern in this disease, in this kind of disease, may also be secondary to spinal deformation. So when we observe a restrictive pattern in this patient, always consider multiple etiology. And then the rarer one is the involvement in Fabry disease. There are only two examples described in literature, to my knowledge, actually, which are not quite new, actually, because the first is from 2007, and we will see in a minute. Again, the anecdotal reports of interstitial lung disease are ground glass opacities. Once again, they are definitely the most common, and they are due to the alveolar filling by glycosphingolipids. And we can also have mosaic attenuation at CT scan, which may indicate small airway disease. As we have just seen a few minutes ago, Fabry disease may be affected by obstructive pattern. So sometimes in these patients, in particular in these two case reports, we observe both of them. So this is the first case report that we are going to describe, the first one from 2007 from Kim and colleagues. And actually, as you can see, there is a difference between the CT scan performed before the enzyme replacement therapy initiation. You can see ground glass opacities, but also areas of the lung that are quite black. They are really dark. It's really black. It's too black to be a normal lung. And these are the areas of air trapping, meaning that this patient also had airway obstruction. And in some areas of the lung, they were overfilled with area that could not get out during expiration. So there is this mixed pattern of attenuation, ground glass opacities, but also overinflation, airway trapping. You see that in this case, the authors of the case reports perform also a CT scan after the initiation of the enzyme replace therapy. And you see definitely an improvement of the CT scan, also both in regard to ILD, so ground glass opacities, but also in regards to airway trapping. And again, also the other case report reported in literature from 2008 report a similar pattern with ground glass opacity. And before the enzyme replacement therapy, the alteration were more consistent. And after the initiation of ERT, so in figure B, you see there was an improvement of the CT scan. So it seems that even is really, really rare, the interstitial lung disease, the interstitial lung involvement in Fabry disease may be improved by ERT. And then, again, the therapy for these cases, so for interstitial lung involvement may be, of course, the specific therapy for every different disease. And in Niemann-Pick disease, is reported in literature, but we have never performed it actually in our hospital. So my experience is only from the literature. In literature is reported the experience of lung lavage performed with bronchoscopy. So with bronchoscopy, we perform an entire bronchoalveolar lavage of the lungs of patients with Niemann-Pick disease with maybe considered as a relative effective treatment. Again, a series of consideration must be done because this exam is, of course, a minimally invasive exam. So the condition of the patient must be taken into account before deciding to perform it. And the experience is mainly in adults patient. Finally, the third and last lung involvement I wanted to talk to you about was the one regarding the chest wall of the patient and also the muscles, particularly the diaphragm, of course, which is the main respiratory muscle. And it can be present in different diseases, in Gaucher disease, of course, where chest wall restriction can be secondary to spinal deformation. Pompe disease, when we may have different expressions, scoliosis, rigid spine syndrome, also sleep disorder breathing, and also muscle weakness of both diaphragm and other respiratory muscles, and then also other MPS and mucolipidosis with stiffening and abnormalities of the chest. So which are the main symptoms we should expect? How can I say, the disease here is even more complex because we may have both a problem of a respiratory problem during the day, but it can cause also a problem during the night, so with sleep disorder breathing. So we may have dyspnea, shortness of breath, which may develop and evolve toward the area, a true chronic respiratory failure with need of oxygen, but also a sleep disorder breathing, and we will see how to diagnose it. It can cause fatigue during the day that is not explained by, for example, by other causes, but also daytime sleepiness, daytime headaches, and also in the more advanced cases, we may have ineffective cough with impairment in airway protection and also in secretion clearance, leading to abundant mucus production and inability to expectorate. So you see a quite complex clinical signs and symptoms. So how can we diagnose muscle weakness and respiratory failure in these patients? We need to perform different exams. Most of them are non-invasive, actually. The one that you see summarized in this slide are performed exactly as we perform the spirometry. So the patient has a mouthpiece and he has to perform, she or he has to perform a maximum inspiratory effort and a maximum expiratory effort. And you need a manometry, of course, because you have to measure the pressures the patient is able to make. And you can measure the maximum inspiratory pressure and also the sniff nasal inspiratory pressure. That there are a wide range of cutoffs that are different according to the age, of course, children different to the adults, and also female different to males. Of course, I did not report on this cutoff for you. However, we have this cutoff and we use it to evaluate if there is a muscle weakness. And again, we can also perform it for the expiratory muscle, measuring the maximum expiratory pressure and the peak cuff flow, which allows us to evaluate the cuff effectiveness. So if the cuff of this patient is effective to clear the airways. And again, once again, we can perform the complete pulmonary function test, meaning spirometry, and we probably will observe a restriction. So not an obstruction, but the other curve that we have seen a few slides ago, the orange curve. So this is not invasive, but again, is not definitive. To evaluate if the patient also have, for example, nocturnal hypoventilation or apneas, nocturnal apneas, we need to perform a polysomnography. Polysomnography, I did not report any picture for you here, but it's not an invasive exam, of course. It's a monitor that we use that allows us to have the oxygen saturation all night long for the patients. We also measure the nasal flows of the patient during the night, and we measure the movement of the thorax and the abdomen. Making together all this data, we can evaluate if the patient during the night have phases of hypoxia, for example, so oxygen desaturation, and how severe it is. But we also can evaluate if there is a situation of hypopnea or apneas, and which kind of apnea the patient has, because there may be obstructive apneas, central apneas, so it's really a huge word. And of course, the treatment is different according not only to the kind of apneas or hypopneas we found, but also the severity of the desaturation and the number of apneas. The number of apneas may be really huge. Recently, we observed a patient, a young adult, which had 80 apneas per hour, meaning that he goes to respiratory failure every time he goes to apneas, and it happens 80 times an hour. So you understand how many daytime symptoms this patient may have. And then again, the only maybe invasive, if we can call it invasive exam to perform is the arterial blood gas analysis. It not only gives us information on oxygen, but also on carbon dioxide and bicarbonates, which is important to evaluate then the response to treatment. And what is the treatment? And we just arrived at the end of my presentation. So the treatment, of course, is disease specific. We have already seen that for the other diseases, but is also to support the respiratory muscles. This is the way we can support respiratory muscles with the non-invasive ventilation. We have a huge amount of way of performing non-invasive ventilation. This is just an example. We need a ventilator, which is actually a computer in which we input the pressures we want to use to ventilate our patients. We usually have a fixed pressure, which is called PEEP, to recruit lung parenchyma. And then we have a pressure support ventilation that only support ventilation of the patient in the inspiratory effort. And we can also give oxygen during the ventilation. You see then that there are tubes to transmit the pressures to the patients, and then we have a mask. This is a big mask. We usually use also small mask, only involving the nose, or also nasal pillows that are more comfortable during the night. So it depends from the type of patient. There are a huge amount of type of mask to choose to. And of course, the results we want to see after we start, usually nocturnal ventilation, is to correct the hypoventilation and the apnea of the patient, and also to correct the daytime symptoms, and also to improve the arterial blood gas analysis of this patient. Many of these patients have diurnal hypercapnia. Usually it is corrected when we use nocturnal non-invasive ventilation. Of course, we start with nocturnal treatment, but it happens that in the more advanced phases of the disease, it may be necessary to ventilate the patient also during the day. And then finally, the other treatment we can propose in the very advanced stages of the disease, when the cuff effort is not effective anymore, are cuff assist machines that actually perform two kinds of pressures. an insufflation and then exsufflations to mimic actually the cough effort of the patient that is not anymore able to do it on his own, and to help the airway clearance to, of course, to prevent atelectasis, to prevent short of breath, and also to prevent infection, of course. So this is the conclusion. I just wanted to give you an overview of really 3 very different kinds of respiratory involvement: airways, interstitial lung involvement, and also chest wall and muscular involvement. You see that the treatment are very different. We can go from bronchodilators to non-invasive ventilation machines. And of course, it is important, even if it is quite a rare complication, it is important to keep in mind, in case the patient develops some of these symptoms, to perform some screening analysis. Spirometry is very useful, definitely, maybe before considering a CT scan or something a little bit more invasive. But always keep in mind that even if these complications are rare, they can happen and can lead to severe complication in the patients. And that's it. I thank you very much for your attention.
Thank you very much, Dr. Faverio, for your nice presentation. I have one question. From what age would you recommend spirometry for respiratory assessment in patients with MPS?
Actually, we work very close with our pediatric clinic in our hospital. And well, there is not a minimum age for spirometry. What is important is that patient must be able to collaborate. So to perform a maximum effort, blowing out the air and then inhale deeply. So usually under the age of 5 or 6, it's quite difficult to obtain such a level of compliance and ability. However, I did not talk about that because actually it's not my area of expertise. However, you can also have an idea of airway obstruction and restriction in patients less than 5 to 6 years using another methodology, which is oscillometry. And it's used in, of course, in very, very young patients, pediatric patients. I have not experience of this technique, which of course is non-invasive because I only treat adults, actually patients or young adults. However, our pediatrician sometimes also perform this method when the young patient is too young to perform a spirometry. But it's definitely very easy, gives similar informations, and can be performed even at younger ages.
Thank you very much. Other question of Dr. Pineda. I think all of them have to have the opportunity and at least try 1 year and see response, even those without GHD. What do you think?
Are you talking about bronchodilators? Sorry, no, about the 1 year.
Yes, 1 year and see response, to see response.
Yes, we actually, in patient, my experience is with Fabry patients. And usually when they have airway obstruction at the beginning, we see them after 6 months. And then if it is stable, we see them with spirometry only once a year. So yes, definitely I suggest to perform a triad at least 6 to 1 year. Less than, from 6 months to 1 year. Less than that is not enough to evaluate. So I agree, definitely, yes.
Okay. I think we have one question to Dr. Candela. Sorry, one moment. Have you seen strokes occur in patients with MPS?
After surgery or independently from surgery?
I think in general, but
in general,
after surgery
also. I am neurosurgeon, so I have not treated any patient with MPS affected of a stroke. We should ask our neuropediatricians.
Okay. I want to thank to the speakers. They gave very nice and complete presentation. Finally, do not miss the next session at Casa Mila meeting room. Thank you very much for your attention. Bye.